Hi everyone. So welcome to today's session on burns. So the objectives are going to be looking at the pathophysiology and the different forms, looking at different tools which can be used to assess burn severity, looking at the initial management steps and fluid resuscitation rules, and then referral on to specialist care. So the case for today is that you've got a 32-year-old come in ED following a house fire. They've got grazes to the face and neck and burns to the trunk and arms and one of their hands, currently stable, and you've been asked to see them. Looking at the different kinds of burns, 5 main kinds are thermal, chemical, electrical, friction, and radiation. It's not an exhaustive bullet-pointed list there, but it gives you an idea of the most common forms. So I'll let you pause and read through those in your own time, just to kind of familiarize yourself with how they may come into contact with these different causative methods. Then when looking at the mechanisms and kind of going into a bit more depth, the key questions and the key answers you need and the things you need to establish are the source and the length of exposure. For chemical, the causative agent and the concentration. With electrical burns, you ideally want to know whether it's a direct or indirect current, as that will have implications on the heart. With friction, typically it's the type of surface and the kind of fall, how they fell, the length of exposure again, whether was it rubbed for a long time or was it just kind of a fall into an uneven surface. And then radiation typically is just going to be UV, so sunburn versus ionizing if they're under treatment of some kind. Key points when assessing are looking at the extent and the depth. So for the extent, you've got a couple of different ways. The key main kind of tool uses the total body surface area, which breaks the body into percentages. The rule of nines, as you can see in part A in the figure, is a more crude way of doing that and assessing. So it gives you a number quicker. And then on the right, you've got a bit more detail, the Lund and Browder chart. Now that chart's really good because it actually takes into account the patient's age. So if this is for children, and it shows you slightly different numbers to what an adult would be, but that's easily found. And then for depth, it's really looking at are they superficial, partial, or full thickness burns, as that will affect prognosis and treatment plans. So for this case, you've got a reminder there on the top right, but you do your A2E assessment, and as you can see, on assessing their airway, they've got hoarse and harsh breathing sounds, mostly exacerbated by a cough, but they are responding, so they're still talking to you. On auscultation, they've got an inspiratory wheeze. The heart rates are slightly tachycardic, they're slightly hypertensive, and they're a bit dry. Their pupils are normal size, equal and reactive to light. Blood glucose is in normal range, and their neurological assessment is completely normal. When you expose the body further, you see the grazes to the face and neck, quite minor, but they've got burns to the trunk and right side, with the right arm involved as well, and some discoloration and blistering of the left hand on the palmar surface. On the MSK assessment, you don't see any obvious bony injuries or signs of fractures, and they've got good ranges of motion. There is some limitation to the motion, but that seems most likely secondary to the pain caused by the burn areas. Now, just as a caveat to this, I would say if you do find that there are any deficits found on that kind of an examination, given the mechanism of injury in this case and the kind of trauma it is, it usually is typical to request plain films just to assess because as this would be considered a distracting injury. So sometimes you've got such a major injury that it distracts you from other injuries, so you don't want to miss any fractures that may have happened as a result of any falls or trips that they took when trying to get out of the house. So looking at associated injuries and complications, the key big ones that we're worried about are inhalation injuries. So that will be signified by a hoarse voice, poor saturations on the monitor. You can look in and around the kind of airway apparatus that we have. So looking at the nose, have they got singed nose hairs? Are they coughing up any black sputum, so carbonaceous sputum? Trauma we briefly mentioned just now. Infection is a big one. So for large surface area burns, or if they're delaying their presentation to medical services, they can be infected. And then fluid loss is something to keep in mind. You can get capillary leakage due to the damage to the tissue, inflammation as part of the inflammatory cascade, and decreased cardiac output, all of which can lead to extravasation of fluid in burns victims. So it's always key and important to get a thorough history. So it's important to ask them their past medical history, delineate any conditions that may impact or impair their healing, such as diabetes, immunosuppression, whether that's via their drug history or due to a condition, peripheral vascular disease. So poor blood supply will often signal to poor healing. And similarly, their social history, looking at smoking, alcohol, and drug use, again, it's likely to affect healing. And family history as well, in terms of whether there's any genetic conditions or skin conditions in the family. Again, it's mainly really looking at skin healing, and these different factors can affect epithelialization and just the process of healing. So investigations wise, always focus on the basics. We want a full set of bloods, and we've listed here briefly what the kind of key things that you're looking for in each different form. So you're looking at infection and blood loss. For the fluid loss, you're looking at the U's and E's. CRP will again signify any systemic inflammation and might be slow to rise initially. And one key one relevant to this case is carboxyhemoglobin. So that's looking at smoke inhalation, as that will bind more preferentially to hemoglobin than oxygen will, as you'll remember from med school days. Another way of kind of getting a quicker measure may be an arterial blood gas. So it just gives you a quick number. However, do be aware that this can be normal in the early stages. So it's important to keep on top of this and keep an eye on this. Imaging-wise, chest X-ray is going to be the most relevant if you're concerned about inhalation injuries or potential complications related to fluid changes such as ARDS. CT and MRI are less commonly used and will be guided by seniors, and they're typically looking at tissue, deep tissue involvement and kind of damage. Special tests can include bronchoscopy, again will be led by seniors and is to do with the inhalation injuries, and further special tests may be done by tertiary specialists. Typically, they'll need referral to a burn centre or to plastics if there's over 10% of the body area affected, or if a critical area such as the hands or face are involved. So treatment-wise, we're looking at basic wound management principles. So debridement of the skin tissue, topical antimicrobial creams and dressing. You want to regularly encourage change to their dressings once or twice a day, and make sure that you're always inspecting the skin underneath. To state the obvious, ensure using non-stick dressings. Wounds need daily cleaning, and you can actually consider oral antibiotics as well, just to cover for any potential infections. Deeper burns will often require more surgical intervention and will need excision and grafting, because the epithelialization process, which is briefly mentioned earlier, just won't occur because you've lost those layers of skin cells. Blistering, I think the key thing to mention is don't encourage the patients not to burst them themselves, and definitely don't do it yourself. It's a massive infection risk as you're removing a layer which is protecting it from the skin flora, so you just need to allow them to drain on their own. Another key thing to consider is tetanus prophylaxis, whether they've had it before, what kind of surface they were on, and what kind of extent of burns they have, and how deeply the skin's affected. Treatment-wise, so looking at the fluid loss that we mentioned, Parkland formula is the mainstay. So this is used to calculate fluid needs for burn victims in the first 24 hours. It's quite simple. They're looking at 4 mils per kg divided by the total body surface area percentage affected. So for our case, if you take the standard weight as 70 kilos for a male, you'd work it out as just shy of 1.7 litres for a 24-hour period. And whilst that's brilliant because it gives you a kind of distinct number to work with, it is still really important to regularly review fluid status for these patients, as fluid can move between compartments quite rapidly depending on how the patient progresses. So the recommendation is every 4 hours for the first 12, and then every 6 hours for the 12 to 24-hour period. And all of this is just to ensure that you are accurately assessing hemodynamic stability, and it guides you for your resus fluids. So just to wrap up, something that we haven't done before, just a bit of a script for a referral onto a tertiary service that I've put together for you guys. And I think the important things to note are just pause and have a read through in your own time. But it's important to mention the important negatives and the important positives. Start off by introducing who you are, though, and what your questions are going to be, just so the person knows what you're talking about. And then it's important to ask for what kind of guidance you need. So that involves telling them what input you've already had, what changes and management you've already started, and then what questions you have moving down further along their management plan, essentially, and what input the specialists may have. So that just gives you a bit of an idea of how to kind of structure that call and how to make sure that you get everything across. And they will always have more questions. So top tip would be just make sure you have the notes and the results on hand. Okay. Hope that all makes sense. Thanks.